Pleasure to be back in Singapore and again to be with my favorite EB community. Thank you very much to DEBRA for including me. And thank you very much, Latko and Ignacia, for including this topic in your presentation. I hope you'll find this interesting. I have to look over there. I'm sorry. This is Sydney, obviously, where I've come from. Only an 8-hour flight this time. This is my conflicts of interest. I've been doing a lot of work with different companies who've been thankfully investing their time, energy, and dollars into EB. And this has been a huge miracle for me, being in this field for over 30 years, to see companies looking at EB and giving us a chance. So I'm very grateful to them. So we're going to talk today about what matters in terms of getting a drug approved for EB. And we have to think in the way that the FDA thinks. So the FDA isn't interested in whether or not you feel good with your new dressings or your new treatment. The FDA is interested in objective outcome measures and statistics. And that differs a lot from what we care about as your doctors and you care about as the patients. So let's have a look in terms of what can we show to the FDA. If we can show to the FDA in some scientific way that we're managing to reduce blistering and that we're preventing secondary infection, that would be a good thing. But we have to think of a scientific way of doing it. And the FDA is used to dealing with what are called outcome measures, and in particular, objective outcome measures. They've yet to approve any treatment based on whether someone feels better or not, apart from perhaps in psychiatry. So in terms of skin diseases, you have to create a score of that skin disease, which has the following criteria. It has to be valid. In other words, it has to measure what's important in that skin disease versus another skin disease. This outcome measure has to be what's called reliable. And reliable means that if two different doctors have to see the EB patient on a different day, or let's say two different doctors come into the room on the same day, but they don't know how the other person scored the patient, you have to be able to show that those two doctors would score the patient the same. And you have to be able to demonstrate that and publish that for someone to believe you that this score actually means something. Not only that, but this score, you can't just say, oh, this patient's mild, moderate, or severe, and we agree on it. But when you give a treatment to a patient and you see that the blisters are healing, the score has to improve. So you have to be able to show that the score is so-called responsive to the treatment that you're giving. And it's no good if that takes 3 hours while the poor patient's screaming in pain. That has to take a few minutes and be not too long or it's too uncomfortable. So it has to be feasible. Now, these are some of the outcome measures that have been created and validated. I'll be mainly focusing on the objective ones because they're the ones that get the drugs or new treatments registered. So for subjective ones, they're interested in them as secondary outcome measures, but they will never approve a medication based on these. So whilst it's good to be able to show that the patient's feeling happier and has improved quality of life, that's supportive evidence, but it's not primary evidence. So in that way, our group focused over a decade ago in creating one of these and validating it for EB. It's called a QualEb, and it works on an individual level. There's also one being created for family quality of life or burden of disease, which was created in France by Christine Bodmer. And then we've been looking to create a functional score that measures how people can manage to walk with EB, because no matter what severity of EB that you have, even if it's relatively mild, it impairs your function. So this is a current project that we're doing, because there's no perfect foot outcome measure yet for EB. Now, in terms of objective outcome measures, people have been trying for a long time, and the Japanese were the first to attempt it. But their score was very simplistic, almost like a mild, moderate, and severe, and it was just for junctional and dystrophic EB. And in the meantime, Celia Moss in Birmingham in England, her group created a score called the Birmingham EB score, or BEB score, which was a good start in the disease. The only disadvantage of it is it doesn't separate blistering that can come and go from scars, which tend to stay there forever. So you want a score to reflect what can come and go easily in a few weeks or months to demonstrate that a treatment works. And we're not talking here just about target wounds that Peter just showed you, where one patient's one wound is with one thing and one wound is with another, and you're measuring complete healing. This is about the whole patient that we're talking about here. And then there's EB-DASI score, which is one that we created and validated. There's an oral score that was created by Julio Salas in Mexico in collaboration with Stanford. And there is blister counts, but they're notoriously inaccurate when it comes to doctors counting up myriads of blisters. And blisters tend to fuse together when they become big. So you can go from 5 small blisters into one huge blister. So if you rely on blister counts, they can appear to be low when they're actually worse. So it doesn't work to just count blisters. And IGA scores, we've had one attempt at doing that for EB simplex. Yet to be validated and was tried in a trial, but so far didn't help. Laboratory measures, we still don't have an accurate biomarker for EB that we could rely on, as occurs in some other diseases. And then there's been a mixed score that's created called I-SCORE-EB, which is a mixture of objective scoring by the clinician, lab parameters by the doctor, which means to do it properly, you need lab parameters every time you measure it, which can be difficult for a patient with EB to have to undergo blood tests every time you want to measure the score, and functional elements which are qualitative, like the QUALEV score. So this is the publication in the British Journal of Dermatology of the QUALEV score. It's a 17-item questionnaire. Each one answered no, a little, a lot, or a very lot. And therefore, times 3 of 17 is scored out of 51, and worse quality of life means a higher score. So in a trial, you'd want to show that the patient's score started off relatively high and hopefully ended up improving, lowering. If the child is too young or can't read and you can ask them the questions, the parents can answer this questionnaire. So in this study of allogeneic cultured fibroblast injections in 5 patients with recessive dystrophic EB that we conducted in Sydney, one of our outcome measures chosen, is this a pointer? Oops, oh my God, sorry, I've done something bad. What can I do to resurrect that? Thank you. Is there a pointer on this thing?
Sorry.
Sorry, I came from running another session at the conference, went to the Ron Park Royal Hotel. Okay, thank you. All right. So you can see here, which was very exciting for us, responsiveness. So these patients seem to be happier to us while participating in the trial, and the quality of life score at the 3-month time point had improved a lot, especially in the psychosocial elements. And try not to laser Zlatko's eye while I point at this. And the average total score, you might want to move. And you could see here, even the functional score improved over time. And this was after only 1 injection. But the patients were each injected with paired wounds, partly with the active and partly with the placebo. So you can't really separate one wound from another with a global quality of life score with this, but at least it showed it improved. And then it's been translated, forward and back translated, and then validated in these different languages and cultures. Some of them thanks to independent work by these investigators, and others thanks to pharmaceutical industry, in this case Shire, who were doing this study of natural wound healing in EB and needed to see how quality of life changed in those patients. So thanks to all of this, we have these now to take part in studies all around the world in different languages. There's Julio, who just landed in Mexico. I was hoping he could be here. Did a great job with doing this in Mexican, Hispanic, Spanish. And now we're going to turn to the objective outcome measures and a little bit about the history of it. So almost 20 years ago, the Japanese developed their indices. Then you see the Birmingham EB score. Then you see our EB-DASI validation was published around this time. And around 2 years later, the I-SCORE-EB composite score was developed and published before it was validated. Personally, I don't publish scores unless I've validated them, because I think otherwise people start using a score without knowing whether it's a good one or not. Another part of validation is to show whether it changes. And with EB, because we didn't really have any treatments that actually made an impact, We had to pick, certain patients that were on things where they were changing how they were doing in order to even test a responsiveness study. And we did that in Sydney and Melbourne and published it in 2017. The iScore EB published their first validation in 2018. And we, in our first study, compared this against the BEBS, which I'll show you, and an IGA score. And in this study here, which I've been showing you today, we compared it against the iScore EB score, and that's been published in 2018. We did it in 2018. I think it was published perhaps 2019 during the pandemic. So basically, the success in clinical trials in EB is dependent on the availability of these valid and reliable scoring tools, which can actually assess and monitor the severity of the disease. These two scores that I'm going to be comparing were independently developed and validated, but they hadn't been directly compared one against the other. And here you see the results of the comparison study that we did initially against the Birmingham EB score. And you see here that both scores had excellent intra-observer correlations. This is very high. If you did one on psoriasis with PASI that the FDA accepts, you'd be lucky to get anything that was around 0.7. So this is very good. And here you see if it's two different doctors doing the score on the same patient on the same day, that they differed. So this wasn't as good when it was two different doctors, whereas this one was excellent. Here, they also published a comparison of their score against BEPS score, but they, for some reason, didn't do the intra-observer testing. But they found a higher correlation with the inter-observer ICC. So the aims and hypothesis for this study were to compare the EBGASI and the iScore EB scoring tools, which is important because in a clinical trial, it's not going to be feasible to do all these scores. The patient isn't going to be undressed for that long to do all of these scores. So which one would be a better one to use in a clinical trial design? And our hypothesis was that this EBGASI, which was created using the same principles for other blistering diseases in dermatology that I've been involved in creating and validating, because for blistering diseases, they need to have two different elements, one which is reversible and one which is the scarring element. And to see, our hypothesis was that there might be a greater inter-observer reliability with this EBGASI score. So how did we do it? The same principle as the other validation studies. We begged 15 of our EB patients to come into my office on a Saturday in my private practice, where I can control the space. I don't have to block other patients from being at the hospital for a day. And these kind patients agreed to come and take their dressings off. And we needed volunteer dermatologists to come in on a Saturday, and some flew up from Melbourne. And we had 3 from Sydney, I think, and 3 from Melbourne who participated in this. We wanted a spread of patients and severities. And first thing we did was to ask them to complete the quality of life tools, both for QualEd and the patients part of the iScore EB in the waiting room. Very important to do that before you undress the patient and cause pain or distress. And then after that, the patients went into their rooms and had helpers take off their dressings. And then we aligned each doctor with a patient. And we had them in separate rooms. And we had a stopwatch available to them in each room because the doctors had to time themselves. They had to be in the room by themselves, no cheating, to score the patients and write down how long it took for using each measure to see if it was feasible. And we had our medical students running the show, telling us which order we had to move room to room with a bell that would ring. I think it was 10 minutes that we had maximum in each room. And so after the scoring session was over, each doctor was then re-randomized to go back and rescore 2 of those patients from that scoring session. This is how you test whether or not you're any good at being reliable amongst yourself. Okay? So by the time you finish scoring 6 complicated patients with 2 different scores and someone's collected your scoring sheets, there's no way that you can remember what you put on that piece of paper a couple of hours earlier. So, no cheating, no phones, no photographs, anything like that. And then We had a photographer as well take pictures of the patients in case we needed to go back and look at what might have happened if there were somehow a really big surprise with the results. So here we go. Patients were all adults. In a previous study, we did manage to get some children, but for this particular study, I think people were just exhausted with the whole idea, and luckily we got some adult patients. Teenagers, some of those who are more healthy, the parents have Saturday sport in Sydney. It's a very big thing. So we did miss out on some EB patients because of Saturday sport. And we had a majority of men rather than women volunteering to be part of this. We had a mixture of different ethnicities taking part. And luckily, we had every major type of EB included: EB simplex, dominant dystrophic, recessive dystrophic, and junctional EB. But some of the other validation studies, for example, didn't even include anybody with junctional EB. And then here are the statistical results. So for EB-DASI, intra-observer reliability, that's the one. Oh, I've done it again, Ignacia, please. Help. Not used to the pointer being underneath. You can see here that the intra-observer reliability again was very good for EB-DASI, and also excellent again for I-score-EB clinician score. And here we have the EB-DASI inter-observer reliability. That's me versus the other 5 doctors. So you see it wasn't quite as good. And here you see correlations between the total EB-DASI score and the clinician score. So they do correlate, which means it's valid and measuring something that's similar between them. Here you have the patient subjective scores, QALEB, and the I-score-EB patient scores also correlating, which is good, measuring similar things. And then, of course, you want, if possible, to have a straight line between worse quality of life and disease severity. But we know in different skin diseases, it doesn't always work like that some patients are very distressed when they have a few acne pimples on their face, and other people have a whole face full of acne and they don't seem to care about it. So it's very subjective how people feel about their skin. And so, in fact, it wasn't too bad, that there was a reasonable correlation between these objective scores correlating with the severity objective score of the disease. The next type of validity testing is called discriminant validity. And this is where you want to see if your score can discriminate between different severities of your disease. Because in different trials, you might want to have, say, moderate to severe EB patients only, for example. Can your score tell you which are the more severe patients? So what you see here is that as the patients get progressively higher scores, you can see that this line is going up more, discriminating some of these patients more so than this I-score-EB is. And what you really want for a score is, of course, for the score to get higher as the disease gets worse. So what you see here with the gradient of the two graphs, when you overlay them here, is that the I-score-EB score is not discriminating as well between the severities of the different forms of EB. And then when you actually look at the mean scores of each subtype of EB, and you do a p-value comparison of the mean score compared to the others, you can see that with the EB-DASI score, that there's a significant p is less than 0.05 difference, even between the dominant dystrophic patients and the EB simplex patients. All of the scores, or both of the scores, could distinguish between the most severe groups and the milder groups, but the I-score-EB couldn't distinguish statistically between dominant dystrophic EB severity and EB simplex severity, even though there's a lot more scarring in patients with dominant dystrophic EB. And then here you see it reflected a different way with the quality of life scores by EB subtype. And this is what I was talking to you about, that more healthy people who are carrying on with normal jobs often perceive the disability that they have from EB to be worse than some other forms of EB. I personally think a lot of this has to do with the fact that they otherwise look normal. People don't see their feet. People expect them to be able to carry on just like everyone else and march around all day. But it really interferes a lot with their quality of life. So you can see, again, that quality of life doesn't always match up with these disease severity scores. And here you see the feasibility of the scores. How reasonable is it to do this in a clinical trial? How long did it take the doctors to score the patients? EBDASI is a bit more complex. It took, on average, 5 minutes versus the other score, iScore-EB clinician score, was 3.6 minutes. But what you're not seeing here is that this score, the proper iScore-EB score, requires blood test evaluation, medical history evaluation, and to score it properly, you have to spend hours chasing blood results and filling in forms to calculate that part of the score, whilst this is an objective disease score only. And that's what the FDA generally likes rather than composite scores. So there are, of course, limitations to a study like this in the sense of cohort size. It's just not practical to have 80 EB patients, nor could I manage to find them to come in for such a study. It would have been nice to have more children included, more female patients. Would have liked to see a broader spread of EB patients' disease severity scores. But of course, if this was a psoriasis scoring exercise, I could have easily got lots of patients there. It's more common and the patients are healthier and they can volunteer more easily. And so basically, it would have been nice to have included more severe patients, but with all their mobility restrictions, it's difficult for those patients to come in and take off all their dressings for a study like this. They did for the first EB study validation that we did of our score. But sadly, some of those patients have passed on now and were not available for this study. So this study showed that that the EBDASI and the iScore-EB scores are both valid, reliable, can be used in studies. But because of the practicality of an EB trial running for months and the fact that doctors do have holidays, do have sick leave, and you need more than one investigator to be involved in a score in the study with backups, it's important that the score that you're using is going to have a good correlation between two different physicians, two or more physicians. So I think that's an advantage of using EBDASI. It's a comprehensive direct comparison between the two outcome measures. As I said, they're both reliable and have convergent validity between each other. But we've already published and demonstrated that EBDASI is responsive to change. And so what about the future? It would be great if someone else had the energy to repeat this somewhere, to compare the responsiveness again of the two instruments, which we can do now that Peter's got this great treatment, because we can totally score his patients instead of just doing individual wound scores. We could do total EBDASI scores on these patients in the open label going into that study, and then we could measure both these scores as the patients go through the BVEC treatment, or hopefully the Filzabest treatment that I'll be speaking about at the conference in the late breaker on Thursday. So it's possible, and I'd just like to thank everyone for being interested in the topic and happy to take questions. Thank you.